If you're under 50, colorectal cancer probably isn't on your radar, but it should be.
This year, an estimated 108,000 people in the U.S. will be diagnosed with colon cancer.
1 in 5 people diagnosed with colorectal cancer are under the age of 55, and it is now the leading cause of cancer-related death among young adults. Today, we're talking about why it's rising in young people, what the warning signs actually look like, and why the conversation most people avoid is the one that matters most. I'm Dr. J. Rutland, and today on The Health Exchange, I'm joined by Dr. Karen Zaghiyan, a nationally recognized colorectal surgeon at Cedars-Sinai Hospital, to separate the myths from the facts and give you the tools you need to stay healthy, especially from behind. Let's get into it. Dr. Zaghiyan, can I call you Karen?
Yes, of course.
Okay, please call me Jamie. Before we jump into the intestines, I want to get to know you a little bit better. From a career perspective, how did you get to where you are right now?
Yeah, so I grew up in Los Angeles. I went to UCLA for undergrad, studied biology, and then ultimately ended up at UC San Diego for medical school. And there I discovered that surgery was the right fit for me, matched at Cedars for my general surgery residency. Spent 6 years there. And during that time, I decided to go into colorectal. So I actually did my fellowship at Cedars too, and I've been in practice now for 12 years in Los Angeles and at Cedars.
So you started practicing here, around 2014, 15, something like that?
Exactly, 2014.
No one knows this. I've never even said this. I was this close to doing colorectal surgery.
No, you weren't.
I went to University of Iowa for medical school and residency.
Okay.
And in medical school, one of the colorectal surgeons, totally cool. She was like the best doctor.
Yeah.
Listened to her patients, just like every room I went in with her, every surgery I went in with her, she always taught me something. And the one thing that people would always warn me about, they're like, hey, you got to be careful. And I was like, what? They're like, she does rectal exams with no gloves.
With no gloves. I had a couple of those mentors.
Right. And I was like, nah, you got to be kidding me. And then we did a rectal exam. And sure enough, she just told the patient, I don't do this with gloves. I think it's better for my finger. I can feel, right? And then she made me do it without a glove. And I was like, dude, this is interesting.
Wow.
Yeah. And so then I ended up doing what I do now, which is crazy. What drove your interest in colorectal surgery?
So my aunt was actually diagnosed with colorectal cancer, young onset colorectal cancer, actually, when I was in college at UCLA. So at that point, it didn't really click. It wasn't like this aha moment, like I'm going to go do this. But that diagnosis kind of hit our family actually really hard. Up until then, nobody in our family had had cancer. Nobody knew what a colonoscopy was. She was 49 when she got diagnosed. So, at that point, I was a biology major at UCLA. I don't even know if I knew I wanted to do medicine, but ultimately went to medical school thinking I would do something medicine-y. And medicine was actually...
Medicine-y?
Medicine-y.
Okay.
So medicine was actually my first rotation. And I had a patient on service who was admitted with anemia. And as a student, you get to kind of go follow that patient's journey along. So I ended up in the GI suite where they were scoping this patient and diagnosed him with colon cancer. And I remember being there. I remember that and thinking it was cool, interesting. Somehow I was drawn to it and ultimately ended up working with that GI doctor doing some colorectal cancer research and had thought I was actually going to do medicine and GI until my last rotation, which was surgery, and had a complete change of heart. When I went on the surgery rotation, I was like, oh my God, this is so cool. Completely changed my application, applied to surgery, got in, thinking I would do actually surgical oncology at the point. And then, but it wasn't until I was a resident actually at Cedars where I think it all kind of just came together. The interest in GI, the cancer, and also figuring that I like the benign diseases that we get to treat with colorectal surgery as well, like IBD. Mm-hmm. And so that's kind of how it happened.
That's funny you said.
But I always say it's for shits and giggles. And because there are too many a-holes in Los Angeles, so it's job security.
I get it. If I were to ask you if you had a patient story that stuck with you, you would talk about your aunt. Is that the story or is there another story?
The one that kind of I still think about this patient to this day is when my young onset colorectal cancer patient. She was actually in her young 20s, like 22 or 23, I think, when she got diagnosed. She was just one of those stories that you hear all the time, had rectal bleeding, newlywed, was actually bleeding on her honeymoon, presented to her doctors and even the emergency room several times with symptoms, never had a rectal exam. Everyone was just like, it's hemorrhoids, you're young, it's hemorrhoids. And 6 to 9 months later, she gets diagnosed, initially locally advanced. We operate on her. I actually had to do a very huge operation on her with like a reconstruction, a colostomy, and her cancer came back so quickly. And unfortunately, she succumbed to the disease. And it was just like one of those things where it was like gut wrenching, in and out. And she was young. And I mean, my staff still talks about her.
My mom's best friend, my mom was like probably 20 or 30 years older than her best friend in San Francisco. And she got diagnosed with colon cancer at the age of like 32.
Oh, yeah.
She died a couple years later. Her daughter was like 3. And it was just like, when I was in college, this all happened. It was one of the things that kind of interested me in medicine. It's very sad to think about. And I think when you think about colorectal cancer, which I think is having a moment right now, and maybe,
sure.
There's ways that it's bad, but there's also ways that it's good because of how it's changed in terms of what we're looking at, in terms of what we can do. And we're going to get into that. But if I ask you the question, what is colorectal cancer? Because when I hear it, I hear colon, I hear rectum. Like, what is it? What's the difference between the colon and the rectum? And, what are the signs and symptoms early?
Colorectal cancer is cancer of the large intestine. So the large intestine encompasses the colon and the rectum. Under a microscope, the colon and the rectum look exactly the same, but the difference is anatomy. So the colon resides in the abdominal cavity, whereas the rectum resides in the bony pelvis. And so the differences in treatment really have to do with where the cancer is rather than the pathology of the cancer. You asked about signs and symptoms?
Like early signs that people may dismiss.
There are no early signs for colorectal cancer, and that's why we have screening for completely asymptomatic individuals. So most early colon cancer, most early rectal cancer may not have a symptom. But symptoms to be aware of is rectal bleeding. And even though people think of rectal bleeding as like, if it's bright red blood, people assume that that's hemorrhoids. Anything that bleeds in the distal rectum will bleed like hemorrhoids. When you have a bowel movement, bright red blood. Colon cancer is a little bit higher upstream, can have more like maroon colored blood, mucus mixed with, into the stool kind of blood. So that's definitely a sign to pay very close attention to. Change in bowel habits is another one. So also tricky because it very much mimics irritable bowel syndrome symptoms. IBS is so common. I mean, a huge percentage of the population has IBS, and the symptoms are bloating, diarrhea, constipation, sometimes mixed. It can change. Those are also symptoms of colorectal cancer. Weight loss, fatigue, those kinds of things are not common. So if any GI symptom is coupled with weight loss, fatigue, a feeling of just being off, or just a change that's consistent, those are signs to not ignore.
One of the things you brought up, and you just kind of said it in passing, but I always like to state this point to my patients, is screening is for healthy people.
Yeah.
If you have a symptom or if you have some kind of abnormal lab value, whether it's anemia or whatever it is, that's not screening anymore. That is, we are trying to diagnose what you may have.
Yes.
So screening for colon cancer begins at what?
45.
And if you have symptoms, and you're 40 or you're 39 and you're bleeding from the backside or you're bloated and you're bleeding, this is a different story than, oh, I don't have to have this done until I'm 45. That is no longer screening, right?
Correct. Yes.
Do you feel like there is shame or stigma with colonoscopies in the normal population?
Oh, huge stigma. The concern that someone's going to look back there and maybe it doesn't look normal. Who's going to do it? If you're a guy, is a girl going to do it? If you're a girl, is a guy going to do it? There's fear about going to sleep. For a lot of people, having sedation for a colonoscopy is the first time they've gotten knocked out for anything. And a lot of people have fear of anesthesia. And so they don't want to get their colonoscopies because they don't want to be put out. You lose control when you're under sedation. So that's a big deal for a lot of people. And then there's a lot of talk about how awful the preps are and how difficult it is, and, people not wanting to prep. So there's stigma, there's fear, there's a lot about having this part of the body checked.
I get it. Like, I understand it. And like, even as somebody who turned 45 today, like, I'm going to have to go through with this, and I'm a physician. I have to accept the advice that I give individuals and give my patients. But like, we got to get rid of that. Like, we're just trying to protect people. We want people to be healthy. And one of the best things that we can do is screen, right? And being able to be screened at 45, I look at as a blessing. I don't look at that as a shame or a stigma, or I don't want anything up there. I'm not doing any of that. I just want individuals to understand that it's their right to be screened and for us to check you. And I'm sure that Karen feels the exact same.
100%.
If you were in a casual conversation with a friend in a restaurant and they're 46 years old and they're talking, do you bring it up and say, have you been screened? Is that something that crosses your mind?
For sure. The hard part is all the people that are younger that haven't had the opportunity to get screened, and they are diagnosed before they've had the chance. Like my aunt, at the time when she was diagnosed at 49, she never had, the opportunity. Thankfully, my aunt did actually okay. So
Did she?
she's with us. She beat it and had surgery and chemo and the whole thing, and she's awesome.
When we think about diagnosing colorectal cancer, right, staging it, in your career, colorectal cancer surgery, diagnosis, and management has evolved significantly.
Yeah.
Has it been something where it's been really easy for you, or did you, because I think you're like my era,
Yeah.
like, how did you deal with that
Yeah.
during your colorectal cancer training?
Oh my God. I mean, so much has changed, right? We used to look at like a patient who was stage 4 and it was like, done. Don't operate on them. Don't touch them. Don't do anything. This patient's done. They have stage 4 disease. And that's changed so much. I mean, we're looking at like liver transplanting patients who have stage 4 disease now. We're looking at immunotherapy, which is shrinking and melting away cancers nearly 100%. So it's really exciting to be a part of all of that. Not to say, obviously all the surgical innovation, the robotics, the different techniques that we have learned throughout, even my time as a surgeon has just been revolutionary.
What are the risk factors for colorectal cancer?
Common ones people assume are, family history, but in fact, most people that get diagnosed with colorectal cancer don't have a family history. Inflammatory bowel disease, IBD, is a risk factor. And then there's the common ones we think about with, poor habits. So lifestyle, sedentary lifestyle, smoking, alcohol, processed food intake, red meat. These are some of the factors that have been implicated.
How strong do you feel about the processed food intake and the red meat? When you're talking to your kids, like, are these things that you're trying to implement in their lifestyle?
I don't think processed foods or processed meats are like the be all end all of it. I do think that there has to be some bigger like environmental risk that we've all been exposed to for generations probably, right? Because I mean, I think most people, especially the younger age groups, I think they're a lot more health conscious than like we were, growing up. I mean, I grew up in like TV dinners and chips and, all the packaged foods that we used to eat regularly. I think the younger generations are a lot more health conscious and like aware of what they're eating. And I definitely try to kind of drive that home with my kids because I do think it's not a 1 or 2 year thing. People come in and they're like, well, I eat healthy. Why did I get a cancer? And it's not really what you've been doing over the past 1 year or 2 years. This is probably a lifetime of exposure to foods and different, environmental things, some of which we may not know. Antibiotics being one of them. I mean, we used to get antibiotics left and right for everything when we were kids, ear infections, every little thing people would get an antibiotic for.
Is there an association between colon cancer and antibiotic usage?
There has been some, there has been some implication about early life antibiotic exposure.
Is there a particular class of antibiotics or just any antibiotic?
Any antibiotic.
Wow.
Yeah.
When I was in med school,
Yeah.
I remember there are certain genetics that indicate, this person's going to have colon cancer at some
Yeah.
point. We still look for that
Yeah,
too,
we still
right?
look for. So Lynch syndrome is the most common hereditary colorectal cancer, right? So somebody who has a family history of colorectal cancer and some Lynch associated cancers should get genetic testing. But again, most people that get the diagnosis don't have hereditary colorectal cancer. The best thing is for the individual with the cancer to get genetic testing. So nowadays we're a lot better at like referring patients for genetic testing when they're diagnosed with a cancer. But sometimes patients come in and they have a family member who is deceased and they don't know if that person had genetic testing, right? And so we dig into the family. And so the easy automatic rule, I don't know if you remember from med school, is like the Amsterdam criteria, is 3 family members across 2 generations, one under the age of 50 with colorectal cancer. And then this is where like the Bethesda criteria come in, or any other associated cancer. So the common ones being like endometrial, uterine cancer, ovarian cancer, stomach, kidney, pancreas cancer. Any of those cancers across multiple generations, especially if there's somebody younger, does warrant testing that family member who is seeking advice.
Is HPV a risk factor for colon cancer?
So HPV is a risk factor for anal cancer.
Okay.
Anal squamous cell cancer, different histopathology than colorectal cancer.
Okay. But
Yeah.
not a risk factor for colorectal cancer, just anal cancer.
Correct.
Because it goes colon, rectum,
Yeah.
then anus.
Correct. So like anal, right, cervical cancer, throat
Alright.
cancer, penile cancer.
Right. Again, HPV, human papillomavirus, is a virus that's sexually transmitted that tends to present itself in either the vagina or on the penis. And so I'm guessing that anywhere those organs are living or whatever they're exposed to, that can lead to that virus being present in that area and increases your risk for those cancers in those
Correct.
areas as
Yeah.
well. When you look at early onset colorectal cancer, which is expected to more than double in the next 10 years, why do you think that is? Do you think it's because of the screening process? Or do you think it's because there is something going on? I can't tell you what it is, but something is contributing to this.
No, so screening has reduced the incidence of colorectal cancer in people over the age of 50. So screening has actually made a huge difference in reducing the risk for people that meet criteria for screening. But the fact that we're seeing the younger onset colorectal cancers, that has nothing to do with screening. I think the screening age should probably be even lower. I think it's an environmental risk that many people have been exposed to. Probably a combination of all the stuff, the processed foods, the sedentary lifestyle, the smoking, tobacco, alcohol, all the different things in combination are probably what is creating the risk. But no one has like a single factor.
If you were the colorectal cancer academic journal, whatever, if you were the god of colorectal cancer, what age would you choose? I'm not saying that you have evidence for it. I'm just asking you just a question from an expert and operating on colons for at least 20 years. What would you say?
Oh my God, it's so hard, right? Because as a clinician, you want no one to get cancer, right? So I would move it down to 20.
Yeah.
The problem is a third of the country who meets criteria for screening has not been screened, right? So let's just say I get what I want and everybody can get screening at 20, right? Right now, the gold standard is colonoscopy. And the wait times for people to get their colonoscopies when they're turning 45 is like months. So all of a sudden, you're going to have an influx of individuals that are going to enter, the screening age, and there's going to create a huge burden on the system, which means it's going to delay access even further. Because remember, a 45-year-old is still at higher risk of getting colon cancer than a 20-year-old, right? So now all of a sudden, we're going to have way too many people that need to get their colonoscopies, and that's going to create a huge, even bigger barrier to access and care. So I think in the best case scenario, all the non-invasive testing that we are seeing now, the stool tests and the blood tests and all these things can possibly allow us to increase access to the younger individuals while not burdening the system. If that makes sense.
No, I mean, I hear what you're saying. The third of the people that haven't been screened, it's not because of access issues, is it?
I mean, some of it
You
is,
think some of
yeah.
it's
If
access
you're
issues?
like a patient living in the middle of like America with like one GI doctor in a 50-mile vicinity, right?
Yeah.
You're going to have a problem with access. Insurance is a problem. There's so many people, even despite the current, insurance system that we have in the US, who don't have health insurance. Fear and all the stuff. Knowledge is an issue.
Yeah, and we all do what we can, right? And you're pumping away doing the screening colonoscopies because it's GI and the colorectal surgeons that do screening colonoscopies, yeah?
Yeah.
How many days a week are you doing a screening colonoscopy versus surgical?
I have 2 half-day blocks where I do a combination of like anorectal surgery, so like hemorrhoids, fistulas, that kind of stuff, and then scopes.
And then scopes.
Yeah.
Okay. In terms of the gut microbiome, which everybody is talking about these
Yes.
days, what does this have to do with cancer in general? Is it a thing? Is it
It
something
is a
that
thing.
you're looking for? Tell me.
Yeah, it is a thing. I think the microbiome is, we're just, barely scraping the surface of like all the research and information we can know about the microbiome. So I think about the microbiome as, there's like a whole ecosystem that lives inside us. We have good bacteria and we have bad bacteria, right? The good bacteria digest fiber
Mhm.
that our body does not digest. So when you eat, let's just say an apple, right? Your body, our metabolism does not digest that. That kind of gets into the colon, and then the bacteria ferment it,
Mhm.
and they produce short chain fatty acids, which, for example, butyrate, right? So the metabolite from fiber feeds our colon cells and keeps healthy colon cells, while we have bad bacteria that are pro-inflammatory.
Mhm.
So when you look at the microbiome of individuals that have cancer, they have dysbiosis. They have decrease in the microbial diversity. So they have fewer types of bacteria in their gut. And this creates an imbalance in the ecosystem that is pro-inflammatory. And we think that it's a pro-inflammatory state that creates a environment for cancer.
What I always say is disease is actually your immune system's response to your environment. And so she's talking about the environment within the colon. And so when your white blood cells get called to an area and increase all of their inflammatory mediators that they produce, and have kappa beta, interleukin 6 especially, like you get a bunch of inflammation in that area, and that can make cells stressed and abnormal and lead to mutations because they're getting injured and they're sloughing off and they're dying off, and so you're creating new cells and your DNA is being reproduced again, and that's just going to increase the opportunity for mutations, and that's what can lead to cancers, especially these colon cancers. And so it's an important thing to consider. The question is, are there ways that we can now control the microbiome?
I mean, a little bit. And perhaps that's where like the antibiotic exposure comes in, right? Because maybe these babies that got, antibiotics just never had a chance because a bunch of their good bacteria got wiped away. But it doesn't mean that you can't do something about it. I don't know if you've heard the term like eat the rainbow. So eat the rainbow. So when we say eat fiber, right, people assume that means take a fiber supplement, right?
Yeah.
So that's what take fiber used to mean, but take fiber now means eat your fiber.
Yeah.
And when you eat your fiber, you want to eat a variety of fibers. So you want to eat all the different colors of the rainbow in the food that you eat. So what you eat on Monday should be different than what you eat on Tuesday and Wednesday and Thursday and whatever, so that you feed your gut with all the different kinds of fiber. Because if you can, just on simplified terms, like imagine each bacteria in your gut is going to nourish itself by one of the fruits that you eat. So the more variety and types of fruits and fibers and whatever that you eat on a weekly basis, you're going to be feeding the diverse bacteria in your gut. You're going to increase microbial diversity in the gut, and that's going to keep the homeostasis. That's going to keep your gut healthy and thriving.
I love that. So if you were to tell the audience right now, like give them 4 fruits and 4 vegetables they should have in the refrigerator every day.
Kiwi.
Okay.
Apple. Maybe like mango, and then avocado. I'm going to count that as a fruit.
Okay.
Right?
Yeah.
And then vegetables, let's see, broccoli, Brussels sprouts, all the ones everyone
Green leafy,
loves.
yeah.
The leafy greens, believe it or not, are great for you. They have all sorts of, the phytochemicals and all that stuff. They're not very high in fiber, but it doesn't mean don't eat them, obviously. But people, when I say eat fiber, people say, well, I eat a salad every day, but that may not necessarily be fiber. It's also beyond just the fruits and vegetables. Nuts are high in fiber. Grains, whole grains are high in fiber. So oats, I love oats. I think those oats are really great for your gut. All of these, promote microbial diversity.
And the reason I asked that question to you is because I feel like a lot of times when patients go see clinicians, we say things like eat fiber, and we say things like eat a diverse fiber diet. But and patients leave and they're like, so that's why I'm always like, I always ask people, well, be specific, like tell them exactly what to pick up. And that's I think it's just useful information for our patients, because then it's like, oh, okay, cool. You want me to get an avocado, an apple, a mango, I'll get some broccoli and I'll eat those. Right. And so I just think that that's important information, because when you think about the metabolism of things and you think about what cells need to be healthy and what the cells that are living with us need to be healthy and maintain our homeostasis, so to speak, just makes perfect sense. When we talk about screening, because that I think is the single most important thing I think we're probably going to talk about today, because I'm getting a colonoscopy soon, I'm very interested in this, okay? How does a colonoscopy work, and why is it so important?
There's two things that a colonoscopy does, right? One, we want to try and diagnose cancer early before it has symptoms, because remember, most cancers don't show symptoms until later. So we're hoping to catch cancer early, but we're also hoping to catch polyps before they turn into cancer. So most cancers begin as a very tiny, tiny little growth known as a polyp. These can be millimeters big and can take almost a decade sometimes to turn into a cancer. So when we do the colonoscopy, we can actually see those under, magnified lens, and we can remove those polyps, thereby preventing colorectal cancer. So I always say colorectal cancer, even though it is the number one cause of cancer-related death in individuals younger than the age of 50, it is actually preventable.
That's super interesting. I've never thought about it in that way. And that's, precisely right. That's why screening is so important. Let me ask you this question. Do you think that there are people who are good at seeing the cancer, they're better? Like that person, like when you say, oh, that person's really good at scoping, are you talking about like how they can maneuver the scope, or are you talking about what they can see on the screen?
So there's something called a polyp adenoma detection rate. So each endoscopist should know their adenoma detection rate. And that's actually a marker of how good the colonoscopy is.
So it's like a handicap, like in golf, it's like a adenoma detection rate?
Yeah. And
so
some centers, they look at that, if they're hiring or if they're doing quality control.
Well, how do they know? If that person's doing the colonoscopy and they're like, oh, they got 3 polyps, and then the patient's, the ass is gone, it's away. Like, how do they know what they missed, or if they missed something?
So a certain number, like 40% of patients that come in for a colonoscopy should have a polyp found. So if you're scoping, let's just say, doing screening colonoscopies and you're not finding polyps, you may be missing them. Yeah.
Okay. All right. It's I've never heard it that way. So it's called an adenoma detection rate.
Yes.
So we know to start at 45 if you're a healthy individual.
Yeah.
It doesn't matter the race, right? If you're white or black, it doesn't matter starting at 45.
So Hispanic, Black, Native American, higher risk. But unfortunately, we don't have guidelines for screening at a younger age. So it is still 45, but it shouldn't be.
Right. So you would say, at the very least, because earlier you said, I want everybody to be screened at 20. I know that you're but you would say if you're Black, Hispanic, or Native American, you would say, I at least want you screened at 40 or 35.
Well, you can't technically get
I know you can't.
Screened.
You can't get screened.
Yes.
But you would.
Don't delay it beyond 45. How about that?
Yes.
Like on your birthday.
Do you think in your colorectal surgery lifetime that the age for minority individuals in the United States is going to be lower?
Yeah, I think so. So when it was 50, when screening age was 50, it was actually 45 if you were Black.
Right.
Yeah.
That's what I thought. I mean, I always had 45 in my head.
But when they reduced it to 45 for the general population, they didn't then reduce it further. That makes sense. Yeah.
For people that are putting off screening, what do you want them to know?
Listen, the best test is the one that gets done, right?
Yeah.
So I would rather you get a colonoscopy, but if you're not going to get a colonoscopy, you're like putting it off, just go get something. Something is better than nothing. Colonoscopy is the gold standard because of what we said, that, with a colonoscopy, we can actually prevent colon cancer. We remove the polyps. You don't have to have the test if it's clear for another 10 years, and we're preventing the cancer. Cologuard, which is the poop in the box test, right, is actually really good at detecting cancer. 95% the new Cologuard Plus in detecting colon cancer. The problem is that the polyp detection is still low. It's like 40 some percent. So it's only going to find about 40% of those polyps that when you have your colonoscopy, we're going to find and remove. So your test may not turn positive until you have cancer, right? Remember, none of the non-invasive tests are diagnostic either. So they're really for individuals that have no family history and feel perfectly normal. They have no symptoms. Now, what about some of the other options, right? And there's a blood test that is now available. Again, the nice thing about the blood test is, like, let's say somebody's come into their primary care doctor 2 years in a row now, and the primary docs said, go get a colonoscopy. They haven't scheduled it. Go get a colonoscopy. Haven't scheduled it. The doc can just draw the blood test right there in the office, and done. That patient's screened.
What are they looking for?
They're looking for circulating tumor DNA.
That's right.
So
okay.
Circulating tumor DNA is cancer DNA shedding in the bloodstream. That can be picked up on a blood test. Now, obviously, the sensitivity for that's going to be lower. It's around 80 some percent for cancer. It's very low for polyps. So again, it's not going to be a cancer prevention test, but if somebody's not getting screened, like that 30% of the population who has not had their testing, it's better than nothing.
Okay. And what about virtual colonoscopy?
There's a population that it's a good test for. You do have to do the whole prep. You have to drink the full colonoscopy prep for your virtual colonoscopy. So if the prep is the issue for you, then that's not a good test. If getting anesthesia is an issue for you, then virtual colonoscopy is okay. Again, it's decent at picking up cancers, about 95%. It's not as good at picking up advanced polyps, so advanced precancerous polyps. If any of these non-invasive tests, either the Cologuard, the blood test, the virtual colonoscopy, any of them show something, if they're positive, now you got to go get the colonoscopy. So if you have prepped to do the virtual colonoscopy and it's positive, you got to prep again to come do your colonoscopy. So I always say, if you can get a colonoscopy, get the colonoscopy. If you can't or won't, then you have other options.
Here's the bottom line. This is the way I look at all this. If you're healthy, get the fucking colonoscopy. Get it at 45. Like, the other options are actually for individuals that have a history of severe disease of some kind. Individuals who have heart attacks, who have had strokes, individuals who had other types of events in their life that prevent them from doing the definitive invasive test, or the risk of doing the invasive test, like anesthesia, outweighs the benefit of what they're find. Or the individuals like, I don't know, 85 or 90 years old, something like that, in which case, they don't want to. I'm not going to scream and yell at those individuals. But like, that's who those other options are for. It's not for the 45-year-old healthy guy that's going to practice law tomorrow morning, or going to work at, a fast food joint or the restaurant, or doing whatever you do. It's not for that 45-year-old healthy person. That person needs to get the colonoscopy. Because the way that I think about managing illness, you want to manage the illness when there are no other illnesses present. And if you're healthy and they just find a polyp, or God forbid, they find a cancer, all you have to deal with is that cancer at that age without any other chronic illnesses. When you delay, you're just accumulating illness over the course of time.
Let's just mention the risk of perforation, because that's another thing that people kind of are really freaked out about. Oh, I had a friend or somebody that this happened to. I mean, the risk of that is extremely low. Usually in my entire career, I've seen a handful of perforations, never perforated, thankfully, anyone myself. But even in the entire global, like if there's a perforation as a colorectal surgeon, me or one of my colleagues are getting called to handle that. So I hear about these, right? So in our like community, I mean, it doesn't happen. It's very rare for that to happen. If it does happen, if it's some sort of like a complex colonoscopy where like something is being done to remove a big polyp or something that they found that would have gone on to become a cancer anyways. So the risk of that happening is really low. I mean, colonoscopies are super safe these days.
Yeah, the individuals I've seen with perf, and I see them because they come to the intensive care unit, like they had a risk of something.
Or something.
They had something.
Yeah.
It wasn't like the 45-year-old healthy person walking down the street.
No,
That's like extremely rare.
Yeah.
So I want to switch gears a little bit. I want to call this the gut check. These are just quick answers, okay? I'm going to ask you quick questions.
Okay.
What's worse, colonoscopy prep or a 5-hour flight with a middle seat?
For sure, a 5-hour flight with the middle seat. I'd rather not go. That's
I agree with you there. True or false? You can feel colorectal cancer early on.
false. You can't feel colorectal cancer early on. Usually has no symptoms at all.
Biggest myth about colorectal cancer you hear constantly.
That I can't get colorectal cancer because I don't have a family history and I'm totally healthy. It's a huge myth.
What's one food everyone should be eating more of?
Kiwi. Fiber.
You love kiwi.
I don't know, I
Tell
love
me about
kiwi.
kiwi. Do you eat kiwi every day?
No, but I should.
I bet your daughters are like, Mom, not kiwi again. Like, that's crazy. What's one food people think is healthy for their colon that actually isn't?
Red meat.
What about keto diets?
Keto diets, not healthy for your gut. It's high in meat.
Yeah.
And we know that red meat is a risk factor for colorectal cancer. I mean, I think it's okay in moderation, but definitely not something that should be like a staple.
What's the definition of moderation in terms of the amount of red meat? Like, is it twice a week? Is it once a month? And is it fatty red meat? Like, is a ribeye worse than a filet? Like, what is it?
Yeah, so we know that charred meat is worse.
Mm-hmm.
So charred meat creates the carcinogen. So cooked over a grill, worse than like if you're going to stew the meat.
That's interesting.
Yeah. Even if you look at like processed meats, right? That like the data is more consistent for. So like bacon, pepperoni, deli meat. I know. I know. Even those, when you look at the increased risk that we're seeing for colorectal cancer, it's a 18% increased risk. So you're looking at, okay, you're looking
How much though?
18%. So a daily intake, a 50-gram intake, daily 50-gram intake of deli meat. So which is like, let's say like a Subway sandwich every day will increase your risk of colorectal cancer by 18%. And that sounds big. People are like 18%, but you know odds ratios, right? That's 1.18 times, right? So it's not a huge increase. That's why.
Increase.
But it's an increase, and it's a consistent increase seen over and over in many studies. So, I don't know. I mean, when you ask me how much moderation is okay, it's like the same question with like alcohol. There's no safe amount, right? But I will say, I mean, I occasionally have a cocktail if I go out, on a day when I'm off call and I know I don't have any responsibility. I'll have a cocktail every once in a while. I mean, some people say absolutely none. I don't have any. Some people are completely vegan and, whole foods, plant-based. I think everybody kind of makes the decision for themselves. I enjoy a steak every now and then, at a nice restaurant.
So if your daughter orders bacon at breakfast, are you like, absolutely not?
No, I let them have bacon at breakfast, but we don't like cook it every day or like make it every weekend for,
I eat bacon like once every 2 weeks. It's so delicious when I eat it.
It's good.
It's fine. What's the best thing someone can do today for their colon health?
Eat more fiber and eat the rainbow. So just put all sorts of colored stuff in your fridge and try to grab one fiber-rich food for each of your meals and all your snacks.
Broccoli, Brussels sprouts.
Kiwi. Kiwi.
Yeah, every time.
I swear.
You love
I swear
kiwi.
I don't have stock in Munchies, but I should.
I've never seen anybody have more of a love of kiwi than you.
Munchies wants to sponsor me.
Oh my gosh. Munchies, let's go. All right. Kiwi. Wait. Give me some more vegetables people can eat. Carrots?
Carrots? Yeah, all of them. I don't know.
Anything in the produce
vegetables.
section.
Yeah.
Other than like your lettuce bag. Like that does not count as an adequate amount of fiber, correct? right? That's,
Yeah.
I mean, that seems like that's what you want to say.
Oh, okay. Artichoke.
Art-
Artichoke is high in fiber, very high in fiber, actually.
Robot surgeon or human hands?
So robots are great. They have really changed like what we're able to do for surgeons. We're able to get into the pelvis better. We're able to see better. There's a lot that robotics has done for us, but there are definitely cases that can't be done robotically. I mean, there's still some cases that are too complex, too multi-quadrant, multi-specialty that is just better done, believe it or not, the old-fashioned way and open.
What's a question patients rarely ask, but they should?
Long-term function. What will life be like with this surgery that you're proposing long-term? What will my life look like?
What's the hardest conversation you have with your patients?
Hardest conversations about an ileostomy or a colostomy, especially if it's a permanent colostomy. Those are really difficult. The hardest thing is seeing a patient like walk away from a curative operation because of the stigma of a colostomy.
What's the most rewarding surgery you perform?
One of the things I do is an intrasphincteric proctectomy. So that means taking part of the sphincter and still doing a reconstruction. So for me, it's rewarding when another surgeon has said, can't be done, but yet we're able to take the rectum out and still preserve the anal sphincter for the patient and reconstruct them. Understanding that that operation does come with some functional implications and patients have to know what they're signing up for, but it's rewarding to be able to do heart surgery and like do it well.
What's the best advice you've ever received as a doctor?
Know when not to operate. So it's actually a saying in surgery, that the best surgeons know, or good surgeons know how to operate, better surgeons know when to operate, and like the best surgeons know when not to operate. I really use that every day in my clinical practice. So often we see patients that, shouldn't have a surgery. Surgery is not always the best thing for somebody. And it's hard to tell a patient, listen, surgery is not right for you. Or I can't do your surgery, or I can't cure your cancer with surgery. But knowing when not to operate is really, really good advice. And it's advice I received early on in my career that's really stuck with me.
I'm sure that there are things that patients have said to you that you'll never forget. Is there something that you want to share?
One of the things that I was told very early on by a patient was that, my confidence and, just giving them hope really carried them through surgery and their treatment. And they really held on to how I kind of, approached them and, told them like, we got this. I'm going to take care of you. I'm your doctor. I'm going to be there for you. And that person came and gave me feedback, at the end of their cancer journey and was like, thank you for doing that. Because I really, I just used your words to carry me through this treatment. And it really stuck with me. So I do that now with any of my, patients who I walk in to see during that first consultation. And there's so much that's uncertain with cancer and with all the different diseases that we treat. And just being able to tell somebody like, look, I know it's your first time, but we've been here and we've done this before and we did it for the last person and we're going to do the same for you and we're going to be there for you and I'm going to hold your hand. That kind of, comfort that we're able to give patients as clinicians and as people that have like walked the path, so to speak, even though it's different for every person. Is comforting.
It's interesting because it's something that we all as clinicians try to shy away from because we don't want to see, you don't want to act overly confident or overly cocky or whatever, which is probably why it was difficult. But it's important. It's important for the other side, for the patient to be
100%.
able to feel good about, what they're going to go through.
I'm not saying like, somebody has like 2 weeks to live and you're like, don't worry, I got you, like,
Right.
But point being that, most of the time hope is valuable and people need hope to be able to like get through hard things. So I think it's okay to be overly confident when it comes to, reassuring people.
Yeah, I think what you said is perfect. I mean, I think like, hey, listen, I know it's your first time, but it's not my first time.
Yeah.
I think that's wonderful. I think something like that is necessary for everyone. I need to be more procedural. I mean, I am, but more procedural, more surgical at times, and people need to be more medical at times. But one of the things I think that's completely changed cancer, colorectal cancer at least, is immunotherapy and its application in your field now.
Yeah.
What is immunotherapy? How has it changed management? And what are the best outcomes you've seen?
So immunotherapy is different than chemotherapy, right? So historically, when we're treating cancer, chemotherapy basically targets the cancer that's replicating and kills the cancer, right? Immunotherapy works a little bit differently, and it works for really well for a subset of colorectal cancers. These are MMR deficient colorectal cancers. MMR stands for mismatch repair. We've seen a huge response to immunotherapy for these types of cancers, particularly rectal cancer. So patients currently who have rectal cancer, if they're tested and have an MMR deficient rectal cancer, will get immunotherapy first as part of their neoadjuvant treatment. No radiation, no chemotherapy, just immunotherapy. And almost 100% of them will have a complete response, which means they can completely avoid surgery altogether.
I find immunotherapy extremely fascinating and useful. Again, you guys know I like talking immunology. T cells have a job to do, and most people ask good questions, which are like, well, if it's a cancer cell, why doesn't my immune system recognize it? Your immune system does. It's just that the tumor cell has a certain receptor on it that tells the T cell to basically STFU, right? And so what these new immunotherapies do is they basically block that communication from taking place. So they either block the receptor on the tumor cell called the PD-L1, or they block the receptor on the T cell called the PD-1. When they inhibit that communication from taking place, the immune system wakes back up and it's like, oh, you're cancer, bro. And then it rushes to that area. The issue with it, some of the things that can happen is obviously when you're activating T cells, too many T cells can come to an area and it can cause an autoimmune itis of some kind wherever it is. But it's really effective because you're really targeting those tumor cells and that communication, and the immune system can recognize it because you're basically using your own body to get rid of the bad cancer cells within your body. And so now when she's going in, I don't know, surgically or maybe even colonoscopy wise, and you're taking a piece of the tumor tissue, you're sending it to look for the presence or absence of those mismatch repair proteins. You're looking for, and you said the word earlier, microsatellite instability.
Yeah.
You're looking for certain genes presence, whether it's KRAS, NRAS, NTK, whatever it is, to give you the prognosis and to potentially look for specific therapy to treat those cancers. And I think the fact that you guys are talking about it and understanding it and seeing how it's completely changing the way you manage these patients, I think it just advances medicine so much further. This is like precision personalized medicine for each individual patient.
Yeah. Every cancer is different, which is why multidisciplinary tumor board is critical, especially for our rectal cancer patients.
I think all of this is amazing. Again, when I was training in medical school, colorectal surgery was like colorectal surgery. It wasn't as medical and as immunological and as molecular as it is now, which sounds like, I mean, you love it. It's super exciting on a daily basis to be able to diversify your thought process and think about all of those things. What advice or takeaways do you want to leave the audience with today?
To just get your colonoscopy. If you're no symptoms, you're 45, just go get it done. Like today, call and get your colonoscopy.
I feel like you're talking to me.
I'm talking to you. And if you're younger than 45, listen, just pay attention to your body. I think, the younger generations, they're more in tune, I think, with how their body functions. They know themselves and they know when something is off. And I very frequently see a patient that comes in and says, I just feel like something is off. And as a clinician, I listen to that patient. And if there are clinicians that are watching this podcast, I want you to please listen to your patients. If your patient's telling you something is off, listen to them. Refer them for that colonoscopy. Don't just tell them they have hemorrhoids without doing an exam. That's not the case anymore. Nobody's too young to get cancer.
I 100% agree with that. At the end of every episode, we always have what's called a positive pulse. Is there a patient story or any story in your career in which something positive happened
what are the stories that resonates with me? Because I used to be very hard-headed about colonoscopies, like very hard-headed. Like I thought every other test was inferior. But I recently had a patient who I had told to get a colonoscopy. I was actually seeing that patient just for hemorrhoids, and they were 45 and I was like, get your colonoscopy, get your colonoscopy. They didn't get their colonoscopy for like 2 years and came back and was like, doc, I didn't listen to you. I didn't get my colonoscopy. I had Cologuard and it's positive. So can I get my colonoscopy now? And so we did, and believe it or not, found a very large polyp that we were able to remove and actually still prevented the cancer.
That's awesome.
So, it's okay. They didn't get it when they were going to get it, but they eventually got it and it was still a good outcome. So it's never late, If you're 47, you're almost 50, you're like, it's been 4 years. I don't want to get it now. They're going to find something really awful. Then my whole life will change. Better now than never.
47.
Better now than late.
47 is almost 50. Wow. That's
I'm
like,
47.
listen.
I've had 2 colonoscopies.
Really?
Yes.
Did you have
Well,
polyps?
because of my aunt.
I get that.
Yeah, I had my first one because of my aunt. I had my second one because I was iron deficient. And I was like, what the hell? Did they miss a cancer on my last one? So I got another one.
Did you just have like your surgeon friend do it?
I'm a girl and I, have heavy periods, and that's probably why I'm iron deficient. I don't know. But yeah, I had the whole upper, I had a wireless capsule, I had a colonoscopy.
And no, listen, there was one time during the pandemic where I had COVID and I took 2 different monoclonal antibodies, Paxlovid.
Yeah.
I did it
Right?
all.
Everything. Because like we see all the crap and
Yeah.
you're like,
Oh yeah.
yeah,
I'm that guy. My wife got breast cancer, same thing. Like it was like boom, like everything was
just
done
get it done.
in half an hour.
Yeah.
Right? Yeah, I get it.
Yeah.
Where can we find you, Dr. Zaghiyan?
If you're trying to find me as a doctor, KarenZaghiyanMD.com, or you can find me on my socials at Dr. Karen Zaghiyan _official on TikTok or Instagram if you just want good content.
Listen, if you want to know content about your ass or your rectum, follow.
Right here.
All right. Thanks for watching and listening. We're on Instagram at the Health Exchange Podcast. Get us everywhere you get your podcasts. We're on every Thursday morning, 6 a.m. Pacific and 9 a.m. Eastern time. We appreciate all the follows. It's 415,000 now on YouTube. Much appreciated. Audio, we're there on Apple, Spotify, iHeart as well. We'll see you every Thursday, as we do every Thursday. Take care.